Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
All right, guys, welcome back to another episode of Life of Flow. This falls along the lines of our case cast series, where we bring some things that make our lives harder sometimes, but certainly make what we do a lot of fun, as it's not always straightforward. But what better way to do a case cast but to do it with who has been referred here shortly before we went live as the godfather in many ways of advanced endovascular therapy. And not only that, but somebody that I hold very close and dear to my heart, as he was one of my first inspirations, a mentor, a person that is not only a phenomenal professional, but also somebody that you aspire to be like at a personal level. And so we did that introduction off the top about who Andrej is. Andrej, welcome to the Life of Flow, and thanks for carving a little bit of time from your day to sharing with us some of your knowledge.
Thank you very much for having me. Really great to be together with you.
Thank you, Andrej, for being here.
That's great. So today we're really talking about complex crossing techniques and in peripheral vascular interventions. And we're going to try to focus a lot on a particular product that we have all found to be of a lot of use because of, I think, a lot of things that we'll talk about it, but it really comes in different, shapes and sizes and accommodates for a lot of the complexities that we now have. And, we thought the best way to showcase what this product is and what it can do in many ways is just sharing some cases that we've had here in the last few months. And certainly Andrej being the person who has the most experience with this and who has shown us a few of these tips and tricks. And then we've kind of put our own little spin on things. I think we're going to kick it off with you, Andrej, if you don't mind. I understand that you maybe have a slide set. If you don't mind, you could go ahead and do that screen sharing, and then I'll give you the microphone, and we'll probably interrupt you a ton as you're telling us about this case and what we have done in the past to get through these. By the way, for all of you driving or on your commute to work today, this is one you maybe want to wait till you get to work, because there are so many good tips and tricks here, and it's going to be very visual for you today. So again, folks, if you're one of those listeners, listen on. I'm sure you'll get some tips and tricks just by listening, but make sure that you are either driving a self-driving Tesla or you're at work or home and safely can look at the screen. Remember, we have a YouTube channel you can log into, or you can also use Spotify that has video capabilities.
Don't see this in your self-driving Teslas. You still need to look at the road.
I think self-driving Teslas is exactly what they should be made for. And you can jimmy rig it, right? I mean, I know people that have weights that you put on the wheel,
and it looks at your eyes, and you have to be looking forward.
Yeah, but imagine you can put your iPhone right at the dash.
Don't
and you
do
can be
it.
watching this.
Don't do it. Don't recommend that. We'll get sued.
I think nobody's going to sue us. If you listen to us in any serious way, you're an idiot. Whoever's listening, if you think that we're going to give you good advice on driving, you probably should not be even listening to this podcast. Anyway,
all right, let's keep going.
Yeah,
Andrej.
okay. Yeah, thank you very much. Thanks once again for inviting me. And it was really a great time when we had you here in Leipzig, Miguel. It was fantastic. We started so many new things, which we still do. So, I thought to give you some few cases, examples where I think the BeBack is really a fantastic solution. Just for the beginning, this is here the device. It's a very slim catheter, 4 French and 2.9 French catheter. So 2 different ones, actually 4, because one is also shorter in length. The other one is also to go crossover or deep into the foot. And you see it's a small needle here in a braided, relatively strong and stable catheter, which you can push with your finger stepwise out. So if you push it only for a millimeter out, it's like a forward-looking needle. A little further out, it takes a curve, and in the right side, you can see it looks rather like a like a reentry device. And by this, you can use it in different ways as a catheter to go through severe calcium, to penetrate through everything which is in your way, or as a reentry device from the subintimal space back into the true lumen. So really, the variety in which you can use this catheter, this makes it, I think, really a fantastic solution. Yeah.
And Andrej, is this an 014 profile catheter or is it an 018?
This is a great an important question. In fact, yeah, so 4 French catheter is a 018 device, and the 2.9 is 014. And because you need this catheter in very complex lesions, often very calcified, a stable wire like an 018 is, of course, very helpful. So this is really an advantage also over other older reentry devices, for example. So here.
So do you have a favorite wire that you, on most cases, pair each one of these up with?
Well, in fact, if you, of course, work over a wire with a needle device, it's always not recommended to use it on a wire with polymer coating, because you may, if you pull back the wire through the needle, shave off the coating. But in fact, we mostly use it with a polymer coated wire. It's the Command 18.
So you use the Command 18 for the 4 French, and then you use the Command 14 ES,
for example.
the smaller one?
Exactly. Right.
I've seen that sometimes it's nice to pair it actually with a CTO.
You can also do this, of course. Yeah, sure. Because, but since, very often, it's not a device which you start from the beginning. And first, of course, you try to get the wire through. And very often you have, let's say, like in that case here, very severely calcified total occlusion. Yeah. If you see this, very unlikely to be able to stay with the wire intraluminally. So that's actually, for me, not a case for a CTO wire. And I start with a polymer-coated nitrile wire, let it make a loop, try to get it through. And since I have then a Command 18 already in, I just load, if I have problems and need the BeBack, load it over that wire. So this is here the case, severe claudication. There was a failed recanalization attempt already. They couldn't get the wire actually into the occlusion. I can see here it's a coronary artery disease patient, also former smoker, really calcified. That's for example, one of the cases where we like to use it. Here you can see already, we tried with a stiff Terumo to get into the occlusion, didn't work. We changed to a Command 18 from above. And if I see this, I usually directly go for an additional retrograde approach. Usually, actually, I try to get a 4 French sheath somewhere distally in proximal tibia. Tibial anterior is usually the place where I take a 4 French sheath in to try to break through from both sides. But as you can see here, also from retrograde, not so easy to get the wire through. At least we could get these wires parallel. Yeah, and of course, now you can try for hours or for a long time to balloon from antegrade, balloon from retrograde. This is in fact what we also did in that case. So you try to balloon from retrograde, you balloon from antegrade to somehow destroy this occlusion, and to find a way now for both wires to find then a channel through the occlusion. But very often, of course, that can take time and it may not be successful. And to shorten the intervention time here now and to make it also successful, very quickly, if we see it's problematic, we take a BeBack catheter in, either from antegrade or from retrograde. And since we have a 4 French sheath in here from retrograde, we took it in here from retrograde.
So I'm sorry, this is the 4 French that you selected to go from the bottom? So tell me what goes through your mind as to when do you select the smaller 2 French versus or 2.8 French versus the 4 French from the bottom?
So actually 2.9 is reserved for below the knee and for situations where, for example, I have a very short occlusion, I'm centrally in, can take the wire maybe through, but nothing follows balloon, nothing support catheter cannot follow. So I take a 2.9 French over a wire, which is already through the lesion, and drill this needle over that wire through the calcium to increase the hole around the wire, and then it's usually possible to follow with a balloon.
Yeah. Andre, I usually, when I do retrograde, I don't put a sheath
Yeah.
in, and I do bareback, usually through a 1/8 or 1/4. Is this something that you've tried? Do this, putting the catheter bareback? Will it
Yeah.
track? Will it go through the
Yes,
vessel
yes,
wall?
absolutely. You can also use this one sheathless. However, I must say,
Yeah.
of course, the tip is a little bit more bulky than a very good low profile sheath like a radial sheath, which you can take over an 018 or 021 inch wire in. And therefore, in fact, I prefer to take a 4 French sheath in and over that load the 4 French BeBack. Yeah.
What I've ultimately been doing is I actually go naked,
Yeah.
and I'll show that when I share my case. But I'll go
Yeah.
sheathless with a
Ah,
small
that's
device,
cool.
even if it's
Yeah.
FemPop, and because I think in many ways when you're using this
Hmm.
device, conceptually, as you think of CTO
Hmm.
devices, all you need is to find a different alternative pathway that may not be the pathway of least resistance. What do I mean? Wires, as you buckle them up and they'll find a plane, and then you're stuck in that plane, right? And it's really hard to find a way to get out of that plane. And CTO wires have some degree of capacity to change, go into a different plane, or get in the middle of the plaque, or move in a different direction. But then sometimes they lack that umph, especially in scenarios like this. And so that's where I feel that distinct champions, which is, okay, I'm stuck in a place. I need to move into a different place. I need to get under a different set, right? I always say it's like an onion full of layers. If only I could get into a couple of different layers, I'll probably find my way through. And that's when that needle really helps you move into a different direction. So, I'll show it in a little bit, but I think this is
Yeah.
great. Keep walking us through
Yeah.
what you were doing.
Yes, absolutely right. I mean, of course, you can use this device here to get this wire here, for example, into another plane, to get the wire from retrograde more close to the wire here, as you see on the left side from antegrade. But it can be difficult and it can take time. And this device really helps you also to shorten, as I said, the intervention time. And this is the problem here. You see that it was not so easy to get both wires into a close vicinity. And therefore, ballooning from antegrade retrograde may not be that successful. And you can also see why we choose here a 4 French device over a 2.9, because through that big chunk of calcium with that denseness and diameter, a 2.9 may be too soft, too weak, and too short. The needle may be too short. So therefore, these kind of cases are clearly for me 4 French BeBack catheter devices. Yeah, and you can see here, I mean, can this needle really penetrate through this severe calcium? Maybe not here, but you may also go a little bit a centimeter higher or so. But here we tried at that spot to now connect those two wires. You can see here, it's a little bit hidden here beneath the 5 here, that marker, this C. This C looks to the side where the needle will go to. So it is actually in the right position, in the right direction, looking into the right direction. But of course, in only one direct angulation, you really never know. So seeing this, we actually changed to now to a 90-degree angle to that one. And we want to see this double T. And in fact, also this in this angulation, we already take the needle out to see whether the needle would slip here in front of the balloon or the back of the balloon here, to really want to see why the needle, or we take the needle out of the housing, it stays central here in the shadow of the balloon. And then we may go back here and see how far we are in. The needle is nearly fully out. If it's fully out, you can still push on the whole catheter to penetrate through the last 2 millimeter or so. And that's what we did here. And we hit the balloon here, and the balloon got destroyed, of course. And when you see the balloon deflating immediately after the needle went into the balloon, you know that you actually made the case. And then you push the wire here into the deflated or destroyed balloon.
So is this wire right now in the lumen of the now
Yeah,
popped
correct.
balloon? Is that
Correct.
what's going on? Okay.
That's the idea of that technique. So this is in this kind of cases, this BeBack is really a very, very helpful device here. Yeah, after that, of course, you take the wire out, you snare it out. This needle is actually not to penetrate one through the calcium, but it's just we take that needle down to the plug to give local anesthesia down to the plug, because every next step will be very painful for that patient here with large balloons ballooning this here. So just take needle down, give local anesthesia, and then take your balloons in.
Do you oversize much in
Yeah.
these when you're subbing
Yeah,
like this?
absolutely. We start with 5, maybe 580, then we take a shorter balloon in for more focal pressure, bigger balloon, 640 high pressure balloon, for example, here already some bleeding. When it starts already to perforate that artery, before we think we have the right size balloon in, we in fact sometimes also take a wire band in, for example, 7 millimeter, and then rupture with the protection of the wire band that artery with a 7 or 8 millimeter balloon. But this is already here the result here after taking superior stents in.
What made you choose a Supera? So you sized it to 6 and then put a
actually,
6 Supera?
correct. We actually ballooned here. I didn't show here every step. We ballooned this here also with a 7 high pressure balloon, and after we took a 6 superior in.
A 6 Supera.
Yeah.
Okay. If you see any extravasation outside the Supera, do you do anything about it? Do you watch it?
Yeah, then of course, then you have to decide before you get this. If I go back, if you see this kind of extravasation, this is, I think, acceptable. But of course, if this is after a 6 millimeter balloon already and you want to go up to a 7, then you should of course be very cautious and potentially maybe then first take a wire band in and then really rupture the artery. But if this here happens, that actually is not of concern. That will see.
Not a big deal.
I love using for this purpose the high pressure 014 balloons. BD has a new line for those. Forget the name of them, but they're like really nice because they're 14. They've got a very small, and you can pre-dilate that very strongly and aggressively. Then go to 5, then go to 6, then go to a 7, and then and then you just deploy the stent like you did. So what do you do with the distal axis?
It was here. You can see this here. So this is why I show you this here. This here was a 4 French sheath in. So we just, while we are actually ballooning and doing everything, all the work here, we have already a blood pressure cuff from outside here. We hardly ever take a balloon in for blocking here. So it's just really a blood pressure cuff from outside, 15 minutes, maybe 5 minutes suprasystolic, then maybe 5 minutes pressure in between diastolic and systolic pressure, and the rest is maybe 80, 90 millimeter mercury. You can see here, usually it looks like this here after that, after 15, 20 minutes.
That's awesome.
Is there a minimal size tibial, like that where you would not put a sheath in?
Yes, theoretically, yes. So in fact, for example, the peroneal artery is usually very small. If this ends here like a 2 millimeter artery, I would probably hesitate to take a 4 French sheath in, although we have done it. Small pedal arteries, maybe not. We in fact prefer to use this proximal antitibial is a very nice artery to get access to because it's usually bigger. And you also have the advantage to be more closer to the problem you're actually dealing with. And here the artery is usually 3.5, and we have actually never a problem here with 4 French.
That's really cool, man. Thank you.
The BeBack catheter is the only angioplasty peripheral CTO catheter that can serve as both a crossing and reentry device. The BeBack's advantage lies in its simplicity, a catheter with a robust, directionally controlled needle that can be deployed to various lengths. As a crossing device, the BeBack can be used with just a slight needle protrusion. When the needle hits the proximal cap of a CTO, its sharp tip punctures the occlusion and opens a path for the guide wire. Once in the occlusion, the BeBack can redirect a deviating guide wire. If the guide wire is tracking in the wrong direction, the physician can extend the needle, transforming the BeBack into a directional device via its curved needle. The radial orientation of the needle can be controlled by rotating the BeBack catheter to create new channels within the plaque. In this way, the guide wire can be steered and maneuvered to cross the CTO while remaining in the true lumen. Finally, if you do end up in the subintimal space, the BeBack serves as a reentry device for returning to the true lumen. The BeBack catheter is the smallest crossing and reentry device available, with both a 4 and 2.9 French diameter catheter, each with lengths of 80 to 120 centimeters. It supports a 0.18 guide wire in its 4 French version, and a 0.14 guide wire in its 2.9 French configuration. The BeBack supports both above and below the knee procedures from any access, crossover, integrate, and retrograde. With its multiple applications and approaches and great pushability and torqueability, the BeBack is the preferred choice for crossing even the most complex CTOs. Choose the BeBack catheter because no patient should be left untreated.
Lucas, you want to go ahead and share your case? Because I think you two actually did your homework where you actually made nice PowerPoint presentations. I, of course, along the lines of the Costa Rican ethos, did not fully prepare, but I have a nice video that I can show.
All right. See, I did my homework. Look at this. Actually, Courtney did this nice thing. I just put a presentation.
No, I'm just going to give you some shit, but we have a new...
I know. I couldn't find it. I know. I could have
wanted to make sure we got new logos, and that's a new logo.
So this is a guy that came in, referred from the Valley. And he came in because he had bilateral extra-anatomical bypasses, AXFEMs, and they were infected, both of them. And one side had a pseudoaneurysm. So we had to, we staged it. We treated the pseudoaneurysm first and then brought him back and explanted the other side. And his indication initially was claudication. So I suspected that when I was done with the explantation, he would have some rest pain. At that time, I did not want to go in and put any fabric or any covered stent in because of the fear of infecting the native aorta, which would be bad. So what I did was I took out the first side. I did a vein patch. He had a little bit of rest pain, not too bad. And then I did the same thing on the other side. And then he had significant rest pain, but manageable. And I did bilateral sartorius flaps on this. So we managed his rest pain, and then I let the whole thing heal. He had a big skin defect in the groin. But from my scan, I knew that I had and from the operation, I knew that I had flow in the SFA. All the way down in both legs.
Lucas, are we just going to blow over the fact that some dumbass did bilateral AXFEMs for claudication?
I'm not going to criticize my colleagues on the internet.
But I mean, who has an extra anatomic bypass for claudication bilateral?
You should not do that. That is correct. You should send that off. And to somebody.
Well, I hope that he at least did a good shot of a exercise program, period. And then if he was really in severe pain, there's pretty good endovascular therapists that could take care of this. Or you could just do an aorta by fem. I mean, look at that distal aorta. Should allow you to do a bypass.
Yeah, I mean, no, for sure. I mean, and if you're in a hospital where you don't feel that that's a safe thing to do, I mean, just send it off,
Just to get this clear. Like 2 single, so cut down on both axillaries and then 2 single, or an
yeah, one failed, they did another one.
Wow.
I know.
Listen, I don't care saying how bad this is because I know the guy that did this will never listen to this show.
That's probably true.
Because anybody interested in education would not be actually doing this sort of stuff. This is heresy.
Yeah. Well, anyways, it was bad. We fixed it. But now the guy has rest pain from claudication. He went into rest pain, and now we have to deal with this. And I kind of knew that was going to happen. So when I did the explantation, I did a really deep eversion, or like tried to get as much of the plaque into the external aorta. I did, I think the guy that told me, like where I saw this initially was Galani over in Houston. He would like release the whole inguinal ligament, raise it up, and then really get in there. And I did that because I knew that I was going to land some stents in there at some point in the mid future. So I let him like chill for a month, gave him antibiotics, managed his pain, and then he was like, "I can't take this anymore. Fix me." So my plan at this point was to do access up from the arm, and then access mid SFA, and then come in and do this endo. So this was my initial access. You can't really see the sheets, but they're just right at the bottom of the screen, and you see that there's patent profundas, and you see up top that there is the left side has more of a tract, I would say, a little better landing zone. It's higher above. The right is right at the femoral head, but still doable. So with this, just a coated wire, 018 with a 035 catheter. My workhorses are Navicross with Glidewire Advantage, and did that, and then came up from the arm and took a shot. And then on the right there, you see we're right at that distal infrarenal aorta. There's some big lumbars, and I have my wires up there somewhere. This is just to get a lay of the land. I took several views and then lined up that catheter with a BeBack. I brought in the 4 French. You can see that little C is pointing kind of towards that catheter up top. Is really, I couldn't get good runs with this because my pack system is terrible.
Lucas, would you mind explaining a little bit of what this C is for those out there that maybe have never used this catheter? What does these little markers mean?
Yeah, the C is like how Andre said. It points towards, the catheter has a little like toggle or not, or toggle, or like a little button that sets the depth of the needle, how far it's going to come out. And when, like how Andre said, if it just comes out initially, if you just press it to the initial setting, it's pretty straight. And as you go forward, the needle takes a curve. And at the end, at the maximum extent at which it comes out, is a significant curve. So that C points to the direction of the curve.
So it's a
So,
radio opaque marker
yeah.
that essentially gives you in a biplanar, view, where that needle is going to be projected. And so along the lines what Andre showed, you want to make sure that you do a few obliques to get a very good understanding of where the C marker is in relationship where the lumen of where you want to get back into is.
Yeah.
So Andre was using it as a CTO wire. CTO catheter. This case, you're using it more as a purely reentry, right? You want to get back into the lumen, correct?
Exactly.
Okay.
This is that. So did that, and I find this more intuitive than other reentry catheters. I don't know. You can really feel when you pop in, and it's really, I like instruments that give you that tactile feedback of success. And with this one, I've used it too for transcaval type 2 endo leaks, and you can really feel when it pops into like a free space, and it's really nice. So the first shot I did, I missed, and then the second shot I got it initially from the left, and then after that, your brain kind of just sets, and I got it on the right from the first one. So more the catheter than me.
So let me ask you something. Did you try to just re-enter initially and you failed and that's why you used it?
Yeah.
Or are you using it because you feel the re-entry is safer and you want to be away from those lumbars? What was the...
I just feel like I have a lot of control. Like, when you re-enter with the wire, you should have control if you're using a like a CTO wire, and you do have that tactile feel. But with this, since I'd had experience with it with the trans cable approaches, I've done a couple cases, I felt really good and really comfortable with it. So, I didn't want to spend a lot of time in the OR with this guy, and the reentry is going to be probably the more time.
It was a primary use.
Yeah, so it was my primary use. This was my plan from the beginning.
Andre, I'll bring you into this. As what's your thoughts of primary utilization in some of these cases? Do you feel that that's a need, or for you it's always more of a backup plan when you can't
Well,
cross?
no. In fact, I think it can be used as primary device. For example, this is one situation. As I said, you can use it in so many situations. But this is, I think, also a very good example because I mean, you really, from your experience, we all, if you try to open up this kind of total occlusions here at the aortic bifurcation, if the wire comes in from retrograde, it usually dissects into the aortic wall. So it's actually, I would say, 99% of the cases that it dissects. And I mean, of course, and then with 99% of, I mean, trying to get the wire into another direction and everything, you could directly take that BeBack catheter to shorten it. Absolutely. I think it's a very good situation to do this like that. Yeah.
I remember moments, and I'm sure you both have seen it, where you get a patient that has like a cold leg from an outside facility after a reconstruction of the aortoiliac. And when you do a CTA, you realize that they probably did a really good job at crossing, but then one of the wires probably
Correct.
crossed a little bit higher than the other one. But then you do the kissing right at the same level, meaning that one of the stents was luminal, but the other one was still in a dissection
Exactly.
plane. And I've seen that happen
Yeah.
so many times. Literally, I can remember 5 or 6 cases in the last few years where that's something. And then what you have to do is you have to cross again, maybe debulk, and then raise up the stents to where they're both luminal. And then that's not a problem. But with this, I guess I like what you're saying, Ed, that the primary use is almost like the certainty that where that needle
Mhm.
goes, that's where you become luminal. Of course, you should probably advocate for using IVUS,
Yeah.
right? Is that what you were maybe going to mention, that you also then triple confirmed with IVUS?
Yeah, I triple confirmed with IVUS because once I deployed a stent, I thought the stent was completely um in the from luminal to luminal, and it was in distally, it wasn't luminal, still like barely at that transition point, and I perfed. So after that, I was like, okay, now I always use IVUS. But what I was going to say is that when I don't know you, but when I if before I used the BeBack, um, if I were going to cross this, my initial cross attempt, it would obviously be bilateral, but I would push from above into the subintimal space or that obliterated space, and then try to cross at the level of the iliac. So I would bring that wire from above, get it into the iliac, and there do my rendezvous. Um, I would not try to come from below, because I just think that that's wasting your time. Because as Andre said, it's just gonna go subintimal. I don't know. Do you have a different approach?
Yeah. If you,
Andre, do you like top to bottom or bottom to top? In other words, I guess.
yeah. So I would first, yeah, I would do it similar to as you did it. I would try to do it from both sides to the aortic bifurcation, where then it usually becomes difficult. And then, yeah, I'll probably take the BeBack from retrograde directly in. So, but I wanted to ask you, I mean, here you said the first attempt was not successful. Are you afraid that the needle may go out of the aorta at that area, create a perforation, which may lead to bleeding here? Or how do you know
No.
exactly where to direct the needle to? So what, yeah, so I can see that the pigtail catheter, it's probably that was your target, wasn't it?
Yeah, the pigtail catheter was the target. And yeah, I'm not, if it's an 018, like if an 018 wire went through it's about the size of an 018 wire. So if I missed, I'm not in a place where there's flow for it to
Yeah.
extravasate.
Yeah.
So I'm not
Right.
worried about it. And I've never had an issue. I probably should be worried about it, but I'm not that worried about it.
But I think having some kind
Right.
of target into where you actually cannot see where's the aorta because it's occluded is, I think, very,
Yeah.
very helpful and gives you a good feeling.
Yeah.
Like the pigtail catheter, what we would maybe do is to take the wire from undergrade a little further down and take maybe a 6-French guiding and direct really the orifice of that guiding catheter right to the spot where we want to re-enter or get the BeBack needle to. And then we, without giving any contrast, we would, in different angulations, really adjust the needle from below so that it will really poke onto the orifice of the catheter. So to create some kind of target from above.
Oh, you bring the
Yeah.
6-French guiding from
Yes.
above, and then you poke
Into
into the
the
guiding catheter.
orifice of the guiding catheter.
Oh, that's really smart.
You feel very safe with
Okay.
this. You know very well you're not outside, you're not puncturing into the wrong direction. And on top of that, you have the chance, if you manage to do this, that you really have already snared, so to say, or catch the wire from below, and it's really in the
Yeah.
right space and lumen then.
Okay, that's really smart. Okay. Yeah.
What
I'll
do you
probably
guys
do that.
quick mention just on your anticoagulation for these you know, aorta iliac CTOs? Do you go full blown? Do you go kind of halfway, and then when you cross, you then catch up, or
Full blown.
full blown from the get go, Andre? Full blown from the get go. I have this thing and it's all voodoo, and I think it was Dirk actually that told me that at that time, but it was like, you know, as you're crossing, maybe start with like 5K of heparin. And then once you get your wires crossed and everything's safe and you feel safe, then, you know, you chase an ACT of 250 and above.
Have you ever caused major bleeding with a wire and a catheter? In the
Yes,
aorta?
I have. Of course I have, man.
Yeah.
If you've never had bleeding and you do this enough years of your life,
No, from you know with like wire L35 wire or like an O18 wire and an O35 catheter, you've caused major bleeding in the infrarenal aorta.
you mean like in an unsuccessful crossing?
Yeah.
I wouldn't know because I'm always successful. And no. I don't think so. To your point, I don't think that it's a you know, a
I
very
don't- yeah.
problematic. You know, it's not a super high risk thing. But I have avulsed lumbars, which have made, you
Oh,
know,
really?
retroperitoneal bleeds. I've had to bring patients back, and you know what I thought would look fine eventually had a bleeding overnight. So you know, it's not, you know, I always say, you know, whenever you're really thinking you're really great at this, the gods of vascular care come down upon you and just hammer your ass to the wall.
I've had bleeding with balloons. I've inflated a 4 millimeter balloon in an iliac and ruptured it. So, but that's where my sphincter contracts.
Yeah, you know,
when-
I
when
don't
crossed.
necessarily think you have to run away from it, but you have to be hyper aware the entire time, and you want to make sure that it looks great at the end, that you have IVAS, that you're sizing things appropriately, that you're prepping appropriately, that you're using these tools to re-enter and not just allowing the wire to by chance go in the right spot. And I think that's a huge take home message here. It's, yeah, I'm sure you could do it, and for a lot of people out there have been doing this, they probably think this is overkill. Yeah, but you know, think of that one time or two where maybe the wire entered in the wrong spot, and now you maybe ballooned it in the wrong spot. Now you have to, you know, maybe raise that bifurcation super high to try to fix a problem that you could have prevented by using a more controlled reentry in a primary way. I think that's a nice take home message for our listeners, you know?
A proxy of control is efficiency and speed. Like this cross was the fastest cross I've done ever.
You know, and that's another, if you're busy and you're doing a lot of cases, you want to also be able to get in and out. You don't want to spend 4 or 5 hours trying to cross this and then your entire day goes to crap, right?
Yeah. So this was the rest of it. IVAS sizing. I first laid the aortic stent, got back in through the other side, and then I built it from the bottom up. with viabond and post-dilated. And on the right, you have the final view. The left SFA doesn't light up just because that catheter at this point is occlusive. It's a 7 French catheter for the viabond. So, but the guy had excellent, excellent flow down the SFA, and his rest pain resolved. And he did great. This is a complicated, it seems like an easy case, but if you look at the whole scenario of this guy, it could have been a disaster. And he went from having bilateral infected axillofemoral bypasses to, having a skin graft over the muscle flap, walking, feeling great, and back in the valley. That's it, guys. Any other comments?
Is he back smoking 2 packs a day?
Probably.
Hey, Andre, what are you guys doing with some of these things? For the audience that doesn't know you well, background for angiologists in Germany is internal medicine. And so you don't have that surgical side for hybrid procedures like this procedure. Lucas, what do you guys do right now when you have the necessity of that collaborative work?
Well, we have in the Department of Vascular Surgery also at our clinic. And if we think a hybrid case or whatever is appropriate, then we discuss it and do it right away. So we're one group.
Yeah, you've merged right now, right? Pretty much into one big group that'll see this. Yeah, yeah. Okay. Well, that's cool. And I don't think there was anything simple about any of these 2 cases you guys have shown. Both really excellent cases. Let me move things along here and try to use the last 10 minutes to share this case. This was a patient that was referred to me with a failed femoral popliteal bypass that had undergone a couple of secondary interventions for patency. And as you can see, you can see all the stents, you can see all the clips, and you can see a very mild amount of contrast because I usually get a very good duplex. And based on the duplex, I determine, kind of what I'm planning on doing. And then I come, and my first runs are just to kind of get a lay of the land from a technical standpoint and decide. So I have a really diseased arterial system here, lots of calcium. I'm going to play that for y'all again. And occlusion of a FEMPOP bypass, clips left and right, SFA occluded in the mid portion, old stents that have been placed to reline the old bypass, potentially the distal stent close to the distal anastomosis, and single vessel runoff in a high MAC case with pedal calcium. You could see the whole thing. This patient's also on dialysis, and he had a gangrenous toe and some mild infection for a wound 2, ischemia 3, and foot infection 2. And this is in my office, huh? This is totally an OBL case, okay, guys? Andre, as you see this case, do you consider doing bidirectional approach off the gate, or are you still going to, waste a little bit of time trying to come from the top and see if you can cross it?
I would directly do a double approach.
Same for you, Lucas?
100%. I would just park the sheath.
Yeah.
As far as it could.
Yeah. So same here. So let me jump to minute number 20 here and show you what we did.
So what can you go over what?
Yeah. So here was my thought process. Okay. Well, I'm not going to try to reopen this bypass. It's been attempted twice. It already has been relined, and it hasn't been attempted to do endo, or if it was back in the days and nobody really tried from above and below. And I have a lot of disease. I have disease in the tibioperineal trunk. I have disease in the outflow vessel. I want to try to get inline flow down to that foot so that I can then, give the ball over to my podiatry partner to start doing some sort of foot reconstruction. And I need to at least get one vessel down to the foot and see if that's going to be enough by, repeating hemodynamics, deciding if the pedal acceleration time is right, or seeing if I need to do even then an arterialization or something like that. But complex case, and a case that I always would think, as both of you guys, I need to come from both directions. This isn't an easy case. And if I want to stay under the 2-hour mark, which is what I put myself as a usual, your cases should never be longer than 2 hours. If you're there for more than 2 hours, something's wrong. You either didn't plan appropriately, or you found some grenades along the way that you should consider coming back and restarting. And especially if you're in an office-based lab, you have to consider, how much is this going to take? Is this safe to do in this environment? Do I have the capacities? Do I have the stents? Do I have the imaging? Everything I need. And honestly, I do believe that I have all those things.
Well, how did you choose? So from what I saw, I thought that you had a P3 target for access, and it seems like you chose mid calf. Can you go over that?
Yeah, there's a here. It's not super clear, Lucas. Sorry. I think here. Like I said, I didn't do much of my homework, but what you can see here is that there's disease in the TP trunk, and then I am unsure if that bypass comes into the PT here or not, but I felt like I
Okay.
wanted to have the capacity to
Okay.
treat this area and treat this area. So if I did a high popliteal stick, it would still be okay. But then I would potentially fall in trouble with these other two very calcified lesions. And here's the other thing is, in a really treacherous distal single vessel artery with highly calcified patterns, I'm also very concerned if there's any clot here, I could potentially knock out that distal alpha. So let me advance this to the minute 20. My decision here is to get a posterior tibial axis. I'm going to run this at 10x time. And you can see that these vessels are so calcified sometimes that it takes you a while to get there. But once that wire is in there, this is a V18 control wire. I have enough umph to potentially get my catheters in. And so, I got a Navicross 18. You can see the angio here now. To your point, is there anything there that's highly diseased, right? And you can see the silhouette of the stent here that is unclear where that landing zone is. Is it that the anastomosis is here? It certainly isn't a P. It's not a popliteal anastomosis based on the anatomy of the stent. It maybe is down here, or maybe it could be even down here. I don't know.
Is that outpouching in the TP trunk the anastomosis?
I mean, maybe. What do you think, Andre? Do you think this may be the anastomosis, and that's
Maybe,
why it looks
yes.
a little wider?
Yeah.
Well, possibly.
You could also maybe have chosen the proximal anter, that little remaining stump here, as an excess.
Yeah.
Like right here?
Yeah. Or a little lower even.
Yeah, I think this is a really good idea. And that's really easy to see both on X-ray with how calcified this guy is, and on ultrasound too, to be honest. We find ourselves in this area. We then create a roadmap, and you see how easy it goes into the wrong spaces. So you have to have a lot of tactile feeling and visual understanding of what you're doing to try to understand where that wire is. But then very quickly you start seeing that this wire starts going into the subintimal space. You see how I'm fighting my way.
What catheter
This
are you
is just
using?
an Navicross 018, angled 018 65 Navicross. And that is a V18. Actually, that is a Mongo 18. So this is an Asahi wire, a Mongo 18. And at that point, I said, okay, well, I need to now start dissecting from the top. Now you can say, well, why didn't you start from the top? It doesn't really matter. I'm going to dissect both ways anyway. So I'm just moving the case along to try to get, into where I need to get. So let me move forward and put it on. I'm going to go at a speed of 30 now, because here it's the minutes of just pushing through and cutting through. And Andre showed this perfectly well in his exercise, but it gets to a point where you're just not getting anywhere, right? I mean, you're getting out of the artery. You realize that the subintimal space, now you've kind of left the subintimal space in many ways, and you have to now redirect. And this is the point where I usually say, okay, I need to use a system like the BeBack. So for me, this is a perfect scenario when I'm like, okay, I'm already exhausted 2 or 3 attempts. I'm not going to be here for hours and hours, and I want to get this case moving along. So then let me jump to the 42 and something mark here, because then what you're going to see is where I elect to put the BeBack from the outside, and I actually do it nakedly, meaning sheathless.
Full French.
So
You're operating naked.
is this a 4 French or is this a 2.8?
That seems big.
Yeah.
Andre, do you think this is the 4?
Yeah, I think it's a 4, no? Yeah, 4.
Okay. Yeah, it is a 4. Yes, look at the size of it. Just in comparison to this is the 035 Navicross on this side, and this is the BeBack. And then remember we were talking about the C? It's this little box here. So along the lines of what a guiding catheter does, that you can direct it from the outside, BeBack gives you that alternative where you just kind of direct it where you want. And so I'm not going to waste too much of y'all's time. Let me go straight to the part where it, you realize that I used it multiple times. It was not easy. But finally here, I want to say, here's where we get close to the part, and I'll play this at real speed. So this is a Mongo wire. Again, you see it because of that little bent in the wire, that beautiful little bent that they have pre-made. I really like that. I sometimes combine it with an Astato 14, but I just wasn't getting there. Even though you feel like that wire is right there, there is something avoiding you getting back into that catheter. And actually, at this point, I had changed for an Astato 14. This is probably an Astato 14 because this is what I use to usually penetrate through these caps and to get back into the luminal. But you're there and you're like, no, man, this is just not going. I'm in some sort of different plane. And you'll see here where what I do is I finally back up the needle, back up the wire, and then give a little projection of the needle just to try to push the wire into a different direction. And I do this a couple of times, and then you'll see how, it finally pops back in here in the next couple of seconds. I push the device forward. I changed the direction of the wire. That needle went into the wrong spot. That one went a little bit closer into the plaque. And then eventually it got much, much closer to the catheter. And then right there, it's in. I think, I won't show you the whole thing. Pull the wire back, ballooned it. To your point, same thing, Andre. Lots of balloon back and forth, creating enough space. And cracking everything open, high pressure balloons, Supera, plus minus Viabon in the event that you think that there's some sort of perforation. But I think these things are very useful when you're doing. And any comments on that used to try to find that little space to find yourself back into the catheter?
I would think I would have tried the popping into the balloon. Don't you think the popping into the balloon technique would be faster?
Probably. I mean, I just the problem with these two dissections seem to be just so far from each other that I don't know if a balloon over here would allow me to find anything you would have done. I'm sure you would have done everything different, Andre. But what would you have done?
No, it's a fantastic case. Really well done. I probably also, enlarge my target where I want to have my BeBack directed to also a balloon. I would have been a little bit afraid. Use the needle in the subintimal space to go forward, upwards, sometimes probably out of the adventitia, then back into. So what if you, take the wire out of the adventitia, back in, out, back in, and then balloon? It may bleed. But of course, at the end with this calcium, it will bleed anyway if you balloon. So probably you're right. And this is not really a big hazard to use it in that way. Yeah, really very well done.
3 complex cases, really fun stuff, great techniques. Certainly it'll get you out of trouble. And knowing that we are finally getting all these great tools that make our lives better and in turn give our patients better results. Lucas, you want to wrap up?
Should we talk a little bit about Link? The moment I tried a reentry, like an aortoiliac reentry, was actually after seeing one of Andre's cases. And then I copied everything in a piece of paper and came back to San Antonio and did one. You turned me on to Link, Miguel, when we were in Houston, and I went and I was like, oh, this is like, it's probably where I learned the most, mostly from, I love the live cases. There's tons of other content, but for me, the live cases is kind of what I set my schedule to.
Thanks for reminding me that we were going to take a minute to plug, the greatest meeting, I think, of all times in so many ways, certainly the greatest technical forum of all times. Just a very quick story. It was 2004. I was at TCT and I was running down a hallway trying to chase Dirk Scheiner down. And I said, I want to come and train with you. And he's like, do you know where Leipzig is? And I said, I have no idea where it is, but I'll find it tonight. And he said, well, it's very, very different from Costa Rica. But if you want to come, I'm putting this meeting together. It's called Link. And we're going to do it in our hospital. So if you come in January, this was August, TCT, if you make it there, you can talk to Professor Biamino and Andre and see if there's any chances for you to come. And that night, I remember going to my dad. I was poor as dirt. And I said, Dad, I need a ticket to go to Leipzig. And he said, I only have X amount. And so it was a ticket that took like 7 different stops, but I made it. And it was at the Park Hospital at the time. It was the first time ever. It was a small, very small venue. And, fast forward, it's become the Mecca in so many ways. I mean, this is a huge auditorium and a big expo. Every single player of the endovascular world is there. If you've never been, you are missing out on one of the funnest meetings. You look left, there's live cases, aortic. You look right, there's venous stuff. You look up, there's carotids. You look down, there's tibial. It's evolved into just the greatest expose of technical capacity. And seeing Andre year after year do case after case after case live in a brief period of time and just make it look so easy is something you want to be able to tell your kids about. It's kind of like saying, I saw Messi play. That's the kind of stuff you want to see, Andre. I know you're a very down to earth guy, but this is the kind of stuff that you want to tell your kids. Oh, you know what? I saw Andre live once. But all to say, I think it's a great meeting. Your thoughts, Andre, for this year? I'm sure I've been behind the scenes with how much work goes to prepare, to get the cases, to get the coordination. What are you looking forward to this year for Link happening here? Not too far from now. We're 2-3 weeks away.
Not too far from now. Yeah, really. This. It will be in 3 weeks, and it will actually be the 20th time, so 20th anniversary.
Oh, this is the 20th anniversary.
Yes. And and we are back in January now. As you know, we had difficult times with COVID as well, and we had to go to May, June, and now first time back to January, where it's nasty outside, cold, and no one wants to be outside. It's much nicer in the conference.
I loved it when it was in June. It was the best.
No. That's the problem. I think part of the beauty of this is that you do it when nobody has anything else to do but to stay in their seats.
Correct.
You make it too beautiful out there. You want to go to all the topless in Leipzig and just be out there and not enjoying the actual meeting that's happening. And it's just beautiful. So
it was so nice.
I think it's great to do it in winter. I think it's wonderful. It's how it was conceptually built. And I think it's going to be a great time, man. And quite frankly, you get the Glühwein, you get the beautiful markets in Leipzig, the underground clubs and bars and stuff. Like, it's beautiful. I think it's going to be great. I'm certainly looking forward.
You've never taken me to one of these underground clubs.
Look, I can't tell you a lot. We'll leave that for another personal conversation. But Lucas and I, Andre, are going to come. I know you're going to be very busy, but hopefully we get a chance to see you and at least share maybe a beer or two, if possible.
Great. Would be nice.
All right. Well, Andre, thank you for your time, and it's been great. We'll be in touch, and I hope to see everybody at Linked 2025 in Leipzig, Germany. Thank you, guys.
Great.
Thank you.
Thank you.
All right. Thanks, everyone.
Love you.
Bye-bye.